All right, let's talk about CT abdomen and pelvis. So, generally speaking, we order a CT abdomen and pelvis. We don't order just a CT of the abdomen or CT pelvis. Reason being because it's hard to differentiate exactly where one begins and one ends on CT to stop the CT scanner. And the other is because pathology runs hand in hand between the two, and also structures that begin in the abdomen go into the pelvis, such as ureters and bladder. So we order it together. Now let's talk about some of the stuff with CT. CT abdomen and pelvis. Reasons for ordering it include evaluation of abdominal pain, flank pain, pelvic pain, including evaluation of suspected or known urinary calculi and appendicitis. Evaluation of renal and adrenal masses and of urinary tract abnormalities within CT urography. Evaluation of known or suspected abdominal or pelvic masses or fluid collections, including gynecological masses. Evaluation of primary or metastatic malignancies, including lesion characterization, such as a focal liver lesion. CT scan is very, very good at being able to pick up cancer in forms of lesions, tumors, and can help differentiate those as well. Evaluation of diffuse liver disease such as steatosis, iron deposition disease, cirrhosis, as well as the biliary system, including the CT cholangiography. So you can see the CT, you can see on CT the ductal system very good, coming from the liver, the gallbladder, and on down to the duodenum. Assessment for recurrence of tumors following surgical resection. The very good use of CT scan is following what happens after treatment for cancer, whether it be by surgical resection, chemotherapy, or radiation. You can see whether or not the tumor returns, grows back, or if there's any metastases of that tumor. Also, detection of complications following abdominal and pelvic surgery, such as abscess, lymphocele, radiation change, and fistula or sinus tract formation. Evaluation of abdominal or pelvic inflammatory processes, including inflammatory bowel disease, infectious bowel disease, and its complications without or with CT enterography. CT is great at seeing the bowel wall and seeing several abnormalities with the bowel. Assessment of abnormalities of abdominal or pelvic vascular structures. And again, it does see vascular structures very good. You can even see plaque formation or any blockages that occur within the vascular system. Evaluation of abdominal or pelvic trauma. Certainly a fast scan might be the first thing that you would do in an emergency room when someone comes in with abdominal or pelvic trauma, but CT scan can definitely help differentiate out more of the structures that are have been harmed, and also exactly what structure might be causing something to show up on ultrasound or missed on ultrasound. Clarification of findings from other imaging studies or lab abnormalities. This is a common use. A lot of times you may end up getting an ultrasound of the abdomen or pelvis, and the radiologist may recommend getting a CT or an MRI to further differentiate what you see on that. And a lot of times it's good to put those together. So you have some ultrasound findings, you have some CT scan findings, and those combined together along with your history and clinical suspicion can really give great insight into what might be going on with the patient. Evaluation of known or suspected congenital abnormalities or abdominal or pelvic organs also. Evaluation for small bowel or large bowel obstruction can certainly be seen on CT. Screening for colonic polyps and cancers with CT colonography, and this was something that came out a few years ago as the next big thing was a CT virtual colonoscopy. The problem with that is that you don't really truly see what's going on inside the bowel. It does give you 3D imaging. That's helpful, but also has some limitations, including the fact that it can't differentiate between a colonic polyp or stool that's remaining within the bowel. So one thing that has to happen is a very good colon prep in order to get a good CT colonoscopy done, but also even then it can be limited somewhat. So it's not used very much at all. It is mostly reserved for patients who, for whatever reason, can't go under sedation and go through a actual colonoscopy. Guidance for interventional or therapeutic procedures within the abdomen or pelvis. And a lot of times we'll order CT guided biopsies of things. So if you see a liver mass that you would like to get a biopsy of and see what it is, you can do a CT guided biopsy of that mass. So under CT guidance, the radiologist is able to go in and actually take a sample of that mass and send it off to pathology. Treatment planning for radiation and chemotherapy and evaluation of tumor response to treatment, including perfusion studies, and CT is great again, as we said before, about being able to look at tumor size and see about tumor spread, so you can see whether or not radiation or chemotherapy is working on the tumor, and also you can see if there's any recurrence of it, any growth of it, any shrinkage of it, etc. Pre and post-transplant assessment, so you're looking at the structures before transplant to see exactly what the anatomy looks like before you go in and do the transplant. Also looking at the transplanted organs later on to make sure that they are continuing to function well and thrive well, such as seeing if a kidney is continuing to stay normal size or if there is shrinkage of that kidney occurring. Non-invasive angiography of the aorta and its branches, and non-invasive venography, and this is a great use for CT with IV contrast, as you can actually see the vascular structures very well, and you can see how much of a blockage there is or isn't as that contrast goes through arteries. So someone might have poor perfusion of their lower extremity. You do a CT angiography and it shows a blockage, and then along with that, you might end up then having a catheterization, basically heart catheterization, that ends up going to the peripherals so that the cardiologist or interventional radiologist can do balloon and stenting, or they might do a bypass surgery such as a FEM-POP bypass, which is a pretty common procedure. And also helps to rule out in a non-invasive way any blockages that might be occurring as well. Just a few words I wanted to mention on contrast in general. Oral contrast is used for most abdominal and pelvic CT scans unless there's a no suspicion of bowel pathology, such as a non-contrast CT to detect kidney stones, or when administration would delay a diagnosis in the trauma setting. So a patient with trauma, obviously you don't want to delay someone drinking their oral contrast, which would take 45 minutes to an hour in order to get the CT scan done when it's an acute situation where you need the scan done right then and there. Most of the time for abdominal and pelvic bowel pathology, you are looking for things within the gut, you're looking at things around the gut, and oral contrast gives you a very good ability to look at that in a better defined way. So in most cases, when it's non-emergent and you're worried about bowel pathology, appendicitis, diverticulitis, etc., you would order oral contrast with the CT scan. You don't do that with kidney stones simply because you're trying to get as good of a look at the ureters as you can to see if there's any enhancing lesions, which would be the stone in the ureter. Contrast within the gut would help mask that finding. Common indications for contrast enhanced CT, just some examples. So you'd want to order contrast with your CT for acute appendicitis, for cancer staging, diverticulitis, suspected complications of inflammatory bowel disease, pancreatitis, and pulmonary embolism, which would be, of course, CT of the lung. The contrast can help give a great insight to each of these, and there's protocol and comments out to the right, which you can look at as well. Non-contrast enhanced CT is generally what we use for renal stones. Most institutions have something called a CT stone protocol, which you can order in that fashion. It comes with no contrast. There's no oral contrast. There's no IV contrast. Why is there no IV contrast? Because the IV dye goes through the kidneys, is filtered through the ureters, and then out through the bladder, and ultimately urinated out. If you were to do IV contrast, the whole ureters essentially would light up, so you would never be able to actually define where a stone is or isn't, since what you're looking for on the CT is a radiolucent area that lights up bright white, that being the stone. So no contrast if you're looking for renal stones. So when do you order a CT with and without contrast? This is something we do very commonly, is order it without contrast followed by with contrast. So the order says order CT with and without contrast, or in some cases without and with. So you essentially scan the person first without contrast, then you inject IV contrast and you rescan the patient. The reason for that is that you can look at structures before and after contrast, which can help you define some tumors, but also you can look for calcifications within the vascular system, and get a good idea of how the vascular system looks. Those calcifications are bright white. Again, they're calcified, so they show up as stone on CT essentially, so they'll be bright white. Then you do it with contrast just to see if there is other pathology there that you need to know about, especially with the bowel. And then these are done on the same day. Like I said, you basically scan the patient and then rescan them with the contrast. So contraindications to IV contrast. There are concerns for using IV contrast during CT, which include history reactions to contrast agents. Someone who has a history of IV dye allergy, for example. Obviously, you don't want them to go into anaphylaxis as you're trying to scan them in the CT scanner. So that would be a contraindication. Pregnancy is a relative contraindication. There is a lot of radiation involved with CT scans, but we'll cover this in a moment. Pregnancy, you can certainly do a CT scan if you need to. It's, of course, about risk versus benefit. And it turns out that CT is not absolutely detrimental to the pregnancy. Contrast, on the other hand, we'll talk about in a moment too with pregnancy. There's no teratogenicity seen with contrast, but there is a recommendation to use a non-iodine contrast. Treatment of thyroid disease with radioactive iodine. So IV contrast, the typical contrast is iodinated, so you wouldn't use it in someone who has thyroid disease being treated with radioactive iodine, just because you would basically be outcompeting the radioactive iodine for the thyroid. Metformin, glucophage, it's a relative contraindication, and it's more so the timing of the CT scan in relation to metformin, which we'll talk about in a minute. But metformin, along with IV contrast, can cause lactic acidosis. Chronic or acutely worsening renal disease, IV contrast does filter through the kidneys very heavily. It is slightly nephrotoxic. And if someone's already got kidney disease, chronic kidney disease, or they have worsening renal disease, then you should certainly be cautious about using IV contrast. It doesn't mean you can't use it, but you should be cautious of it. And again, it goes back to risk versus benefit. The other thing you can do is try to help keep the person hydrated well before, during, and after the scan. So you can give IV dye, IV fluids before you give them the scan with the IV contrast, and then give them lots of fluids afterwards as well to try to help flush that through their system and help their kidneys clear it quicker so it doesn't sit in the kidneys causing nephrotoxicity. Also, if the patient already has a nephrologist who sees them, you could also consult with the nephrologist to see if they have any recommendations and if they're okay with you doing the contrast. Contrast may also be avoided when a suspected pathology is likely to be visible on non-contrast enhanced CT. And, basically, if you can do it without contrast, then don't subject the patient to IV dye, which does have risk, including nephrotoxicity. And examples of that would be CT stone protocol. Metformin, just again, a quick note, US FDA advises metformin should be withheld at the time of IV contrast administration for 48 hours afterwards, and resumed only after reevaluation of renal status. In other words, making sure that the patient's creatinine returns to baseline. So ideally, you would hold metformin for 48 hours before the scan and 48 hours after the scan. The problem, however, is that most of the time we're getting scans done on a non-elective basis, meaning that they're needing the scan done acutely. Therefore, you don't have the luxury of waiting 2 days with the metformin held in order to do the CT scan. Someone you think might have appendicitis, you don't hold the metformin for 2 days and then scan them. But you should absolutely hold it for 48 hours after the scan. Have the patient drink lots of fluids or give them IV fluids to flush their system good. Make sure their creatinine gets back to their normal creatinine level, and then you can restart the metformin at that time. And again, the reason being because if you don't, you risk lactic acidosis. In pregnancy, iodinated contrast does cross the human placenta. There's no mutagenic or teratogenic effects been shown with non-ionic low osmolality contrast in animal studies, so that's certainly an option. The American College of Radiology does recommend using IV iodinated contrast for pregnant women when the information needed affects the care of the patient and fetus and cannot be obtained without contrast, and when the referring physician thinks that imaging could not wait or should not wait until after the pregnancy. In other words, it's, again, risk versus benefit. So if you need to do it, you can do it. You can scan them and you can do it with contrast. But again, it's risk versus benefit. Can you really do this only because you can't do something else, such as an ultrasound? If an appendicitis has a pretty good sensitivity on ultrasound. So can you ultrasound the patient and not subject them to radiation or contrast, but potentially?